I will inform my partner, that means study partner, to join, because she was also asking.
Sure,
Okay.
we can get started then in a few minutes. If we can wait for a few minutes. Yeah, sure.
Hey, doctor, I have one question. Regarding patient, if when she attend to hospital and she has that mean moderate pain in case of the ectopic pregnancy. Okay, that means we are going to discuss for her the option that's available: expectant and medical and surgical management. That means, sorry, if the pain is significant. Okay, in the first, that we should discuss about the surgical option instead of the medical and expectant. What do you think? Or we will go to discuss step by step, and we can tell her this is not suitable for you because she's in significant pain.
Yeah, because you will have to discuss the surgical option in quite a lot of detail. So it's better to get rid of the conservative, expectant management and the medical in just one sentence, expectant management, and 2 sentences of medical management. And you can, you can always say that we can explore that later if you have any questions about it, because as I proceed, you will see that it's the surgical option that is safest for you at this point. Then you can start talking about. So just don't, if I was you, rather than putting it towards the end, because there's so many questions, we have to talk about it in detail. We have to talk about open surgery and laparoscopy. We have to talk about self-injectomy versus self-ingotomy, isn't it? So there's an end of follow-up and all that. We don't want to forget one sentence about about expectant and 1.5 sentence about medical, isn't it? We can get rid of them, just get over and done with in the start, and then say that I'll talk to you why I think that they're not suitable options.
That means from the beginning, because possibility we might forget at the end.
Yeah. The easiest and the things that will have a tick box on the examiners, when they're marking you, you're not talking to the examiner, but still they've got a marking sheet there, isn't it? So you will just say those 1-2 sentences in the start, so that they know that you are talking about the options and you are saying that is safest to go ahead with. Okay.
Yeah, and regarding we can tell for the patient surgery, or we should tell her operation. Which one is layman language?
Say it again. Sorry.
Operation or surgery, we can explain by layman language. We should tell the patient.
There is no difference. Both are fine. There is absolutely no difference in surgery and operation. Okay. Both are absolutely fine. Okay.
Yes.
You remember, you're not talking to overseas patients who have got a problem with language. You're talking to UK patients, and surgery and operation both are same for them. Okay, there's no difference.
Yeah.
Okay.
Yes.
Hi Shamim. Hi Sadia. Dr. Sanad. Everyone, Assalamu alaikum. How are you?
Hello, Doctor.
Hello.
Salam.
How are you?
I'm good, thank you.
Yeah.
I'm good. Thank you so much. So,
hello Sam, how are you?
Yeah, hi Sadia, how are you? I'm good, alhamdulillah. I'm fine. Yeah, I'm fine too. I hope you guys are good too. Yeah. So, are you guys ready to bombard me with some few things that you think are included in communication with colleagues? And because it was a burning topic from Sanad, I'll start with him. So the spotlight is on you, Sanad. What would you say?
Yes, hello, how are you doing, Sam?
I am good, alhamdulillah. How are you?
I'm fine, alhamdulillah.
Good.
Fine to see you.
I'll pick up a pen and a paper, because when you are talking to me, giving me points, I will be jotting them down. Okay, so let me break the paper. Because I'm an educationist. I would rather have a two-way flow of information here. Okay. So you will tell me, what do you think is communication with colleagues? What will you include? And here's my paper and pen. I'm going to write.
Yeah, that's great.
Okay. Fire. Are you ready?
Yeah.
Okay. What are
Okay.
the things that you think are included in communication with colleagues?
Again, Sam, please rephrase the question.
Okay. What when you said that your colleagues appeared in the exam, and most of them, they got not reached, like they failed in the communication with colleagues
Yes.
domain. Yeah? And
Yeah.
what impression did you get? What the hell
Yes.
is communication with colleagues? What on earth is this communication with colleagues?
Yeah, okay. So many of them, Sam, I think we do some also partner study sometimes, and we have a particular like stamp we speak. Maybe this stamp have problem in itself. Like we will refer for the patient lay language, we will refer you for multi-expert team who have detail about your condition, and they will decide which called MDT. So
Yes.
this stamp may be not sufficient to be calculated as a communication with colleagues. This is my suspicion. So if we
you
need
think that
to go further,
the way you're talking to the patient, if you talk the same way to the colleague, that's not good. Yeah, this is what you're saying?
yes, yeah,
This is a valid point. Yeah. What else?
yeah, and also the stamp we all memorize maybe not suffice to pass the communication with colleague. For example, I will discuss with your specialist or write back for GB. Do we need to go further in the detail of the communication? For example, I will discuss with your, for example, diabetic patient. I will discuss with your diabetic doctor regarding the doses and how will be the best management for your control the sugar all the time of the pregnancy. Do we need to go further at this point to be valid communication, or superficial like stamp we will refer for a specialist, refer for the multi-expert team to discuss your condition and have a plan for you? Yeah.
So if you if you remembered, you are saying, should we specify or should we say it in general? This is what you are saying.
Yes.
Okay. So to be honest, both will secure you marks. That's fine. Both is fine. If you remember who, and if you have time to say, to include neurologist or endocrinologist or whatever you want to, okay? If you included that, that's fine. If you're struggling with time or you just forgot about it, then that's fine. If you said MDT, if you said specialist, then you will still get that box ticked. Anything else that you think comes under communication with colleagues? Who is the Zoom user? Whose username is Zoom user? Hello, hello. So could you talk to the group, please? Zoom user? Hello? Can all of you have a look at your screens and whose username is coming as Zoom user? Just give us a name. It's Alia. How are you, Alia? Oh, that's all right. Why are you saying sorry? Okay. Oh, okay. That's fine. Absolutely fine. You are at work. That's fine. Anybody else? I think I think Sanad received somebody like he got busy. So anybody else wants to say something about what are the things that we'll include in communication with colleagues, please? Sadia, do you want to say something? What's included in communication with colleagues? Come on, girls, wake up. It's not my exam, it's your exam.
Hello, Sam. Sunanda here.
Hi, Sananda. Hello. How are you?
I just wanted, thank you. I just wanted to know if the letter says midwife has referred to you instead of GP. Should we have to write back to midwife? I got this one question from one of the group.
I think I replied in our group. What did I reply?
I didn't see that. I didn't see that.
I replied, look, I do my work. You guys have to do yours as well. Yes, you will. Whoever refers you, when you can either you can either include them together or you can write separate letters. But yeah, you will definitely reply to GP. You reply to her and update the GP about the situation. So 2 letters there.
Okay.
Okay.
Thank you. Yeah.
Very welcome. So that is another element of what?
Yeah.
Hi, Sam.
Yeah, there is one. Yeah. Okay.
Hi, hello. Who said hi, Sam?
Oh, I think Dr. Sanad is talking. Okay.
Yeah, so Sanad, please go on. You were telling me
Yeah.
about.
Okay, so we are used to use this communication in the management plan and also in the closing of the station. But sometimes we forget to use this communication with a colleague, especially in the emergency situations, especially if we speak about the collapse, the eclampsia, these emergency situations that I need, of course, some notion of help. But what I will do by this help will come, maybe lose this communication at that time.
Yeah. Why do you think you forget it? Why do you think you forget in emergency situations?
Because when I try this many times with my study buddy, so I concentrate only for gush to the management in detail, without respect for the colleague who will do what, which who will help in the resuscitation, for example, who will do stick sample. Yeah, I rush to enumerate the steps of emergency, of resuscitation, of the, for example, the eclampsia, like that. Yeah.
Sorry, I missed the last few seconds what you said.
Yeah, in emergency, I rush to enumerate the steps rather than managing the situation as a whole.
Yes, Anna. If I give you a tip on this one, okay?
Yeah.
You have to really focus on that. Yeah. If I give you a tip, you should not be forgetting this point. Yeah. So whenever there's an emergency, the first thing that should come to your mind is, oh, I cannot do this alone. Okay. That should be the first thing that should come into your mind. And you remember one thing, okay? Hi, Nazma. Could you guys rest of you switch off the mics so that it's not distraction? So Sanad and everyone, what I'm trying to say here is that if you go in wherever there's an emergency situation, you know, the psyche of all the candidates is, all of us, is that the examiner wants to hear from us like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, all the steps. Okay. But before that, if you focus that, you will anyway tell them the steps, and that there is not really a patient lying on the floor that you have to talk of all the steps in, you know, in such a rush. It's only an examiner. So you can delay a few seconds. First of all, you will focus on the thing that, oh my God, I can't do this only on my own. I can't do this alone. When I say, oh my God, that's not to give you a panic. That's to give you a feeling that this is a situation where I need experts. If you go in with that and first of all focus on that I will need all of these people with me, and after that start describing, this is what I will do. We all have this feeling that if we didn't start talking about, you know, in a rush, that press the buzzer, do this. So press the buzzer. What is press the buzzer? Press the buzzer means call for help. But then also mention that who will you need? Okay, all the team members. You just just relax about it and tell them, because that is a big tick box. If you didn't get that ticked, you lost whole of the domain in that station. Okay, whilst you can forget about, you know, 1 or 2 things in the management, that won't lose you marks. You will lose marks here. What do you say, Sanat? Does it make any sense?
Yeah, of course, especially if I give the impression from the beginning of the station.
Yeah.
Even if I lost some points in the core of the station, of course, I save myself in the beginning.
Absolutely. Don't risk it. Don't leave it to, I will tell when it comes to telling, because if they start asking other questions and if you get distracted and you went into, you know, all that management and all that stuff, it's very easy to forget these things. So I think I mentioned the other day as well that when I talk about agenda, I split it into 2, but I just say it right in the beginning that I'll write to your GP and I'll give you leaflets. Okay. I don't say it in 5 sentences clumped together. I say it in 2 sentences first. She says, okay. I said, okay, very good. And then I say the rest of the 2 sentences. I will give you leaflets as well, and I'll write to your GP. So I split it, but still I say it in the beginning because I don't want to lose marks. I don't want to lose that tick on the box. Okay.
Yeah,
so just
that's
like
great.
that. You will do this right in the start. Don't worry. Examiner won't think that this is an emergency situation. Patient is dying and he's talking about colleagues. They won't. If you phrase it properly, that this is a situation where I will need input from all the relevant colleagues, and depending upon the situation, which I will talk later, I might need input from intensivists. And, you know, even for instance, if it's a cardiovascular collapse, then cardiologists. If it's a, you know, a bleed in the head, neurologists and neurosurgeons. So you can mention right in the beginning. You don't have to tell them 10 people right in the beginning, because 10 you can tell them in the station. But you mention that I will be focusing on who I am contacting with. Say it in the beginning so that they know that you are not ignoring the importance of your colleagues, and mention it in the beginning that I'll make sure my consultant is made aware. Okay, and he attends. Okay.
Yeah, that's great. Okay.
Yes, you include
also
all of these then. What else would you count as communication with colleagues?
Yeah, I have also scenario, Sam, if you don't mind, we can discuss this scenario, which really amazing in the communication rather than the applied knowledge, which speak about the case who came twin after 6 p.m. And has some discomfort, and this we don't have the notes for these twins before, but the patient can give our some notes regarding twin-to-twin transfusion before, as well as the patient in contraction, and we don't have code available. So many communication in this case is there. If you can take us and brace especially for communication with the colleague for this scenario.
Yeah, sure. Why not? Go on, fire. So what are the details that you have? How many weeks is she, and what are you doing?
Yeah, it is.
What do you have?
I think it is 27, 28, less than 30. Yeah.
Okay. Yeah.
We don't have code available, and it is 6 p.m. So fetal medicine unit closed already, and the patient in labor, some contraction and some abdominal pain. And
so when you say fetal medicine unit closed, Sanad, what do you mean by that?
After 6 p.m., I think my knowledge also from one there in UK speak about the fetal medicine unit closed by 5 p.m. I think. Is that right?
So fetal medicine unit consultants could be gone, okay? But would you not, if it's a matter of the court, is it the fetal medicine unit you would need to talk, or is it somebody else?
We don't have too much notes regarding her management of twin-to-twin transfusion. So yeah, so this patient have some points regarding the management before for the twin-to-twin transfusion, and maybe the baby have some problem like acute transfusional syndrome again. So if we try to refer directly now for fetal medicine unit, it is closed. So
Okay,
because I am in a
what will
tertiary,
happen normally?
Yeah.
If she is in the same hospital, if she's a patient of the same hospital,
Yeah.
we will have electronic notes. This will be very unusual situation when we don't have her notes. If she's coming
Yeah.
from another hospital, then that's a different story. If she's coming from another hospital, our hospital doesn't have her records, okay? And you know, her handheld notes are not saying a lot, or she's not having them with her. That's a different situation. If she's a patient in our hospital and we don't have her set of notes, we will still have our electronic records there. So for me to go through with this one, pour out all the information that you have, then I can comment on that as well, okay?
Okay. And regarding the transfer for this patient because of no code available, so in utero transfer,
yeah, in utero transfer.
How can we arrange this communication issue?
What issue, sorry?
Yeah, when I do in utero transfer, this patient we don't have code available, and when I discuss with my consultant, the patient is in early labor, I should arrange for in utero transfer because the code level, I think it is level 2 care, and we don't have this code in our hospital.
Absolutely. So she comes in, you took a history, you took a detailed history, you did the examination, you tried to look for the investigations and all that. And and sorry.
Yeah.
So you took all, you did all that, and then you don't have any details. You know that she's only, you know, but from her history that she's 27 or 28 weeks. You how did you get the idea that she's twin-to-twin transfusion? Is the patient telling you?
It is mostly through the notes. Yani already we take permission from the patient to go through her note. This is an information gathering while we're doing the station, and then
the patient knows that she has twin-to-twin transfusion.
Yes, which is managed, and she do her follow-up regularly with the fetal medicine unit, and the last check maybe about 1 week, and everything is going well. But she come by pain right now. And when examined, it is about 2 cm cervical dilatation.
Is she a primary gravida?
Yes. And already the baby CTG is accepted, reassuring because it is normal. The decision after consultation with your consultant on call is to do in utero transfer.
Yeah.
This in utero transfer have a plenty of communication with the colleague.
Before in utero transfer, have you managed her? Have you given her some tocolytic?
Yeah, of course. I speak the scenario. We know in detail about how to do the preterm, the arrange steroid.
But you are focusing on communication at the moment.
Yes, exactly. So I speak about the communication with colleague issue in this station because it is a plenty of communication with colleague from the beginning.
Yeah. So first communication that I haven't heard, I have missed from you. First communication would be, have you spoken to your own consultant about this patient?
Yes, exactly. Yeah.
Yeah. So your consultant is the first one. Okay.
Yeah.
Sorry.
Of course. Yeah.
Sorry for interruption. The consultant.
Yeah.
Sorry, the consultant is the one who will contact the pediatrician in other hospital, or that means the ST5 will contact that.
Yeah, let Sanad go through that. We will be coming to that point. We are not yet reached that point. Okay.
Okay.
Yeah.
Yeah. So if we decide in utero transfer, first I will discuss for searching for available code whenever it is available. So me as a obstetrician should speak with the obstetrician there regarding the case registrar. Then I will ask my pediatric doctor or neonatology doctor to speak with the neonatology doctor there, and I will arrange with the coordinator midwife the issue of having expert midwife to accompanying the woman in the ambulance and write a good referral letter and one hard copy with the patient and one copy in our hospital record, speak in detail about the issue and the details of the patient, and contact by the end the ambulance that will transfer the woman and the midwife, and ask the ambulance by the end to return back by the midwife, and instruct the midwife at any moment of time during transfer. If there is any emergency happen, she can go directly for the nearby maternity unit. Is that correct?
Go directly what?
To the nearest maternity unit.
Yeah.
So all this process of communication makes sense at right, because we don't have guideline, only we search about some protocols.
Yeah. So one thing that I'll tell you is that if you mentioned various people who are involved, like you mentioned quite a lot of people, okay? So if you mentioned these many, and if you forgot one or two, I can reassure you that you will never fail communication with colleagues if you mentioned these much people that you have mentioned, okay? To fine tune this, you should always, yes, you could lose a mark, like you could lose a pass and go down to borderline if you didn't involve your consultant to begin with. That's a very important step, okay? You can't, with this kind of, it would give impression that you are feeling too much of freedom and too much of independence and you didn't consult your senior, okay?
Yeah, the decision to transfer is the consultant decision. After the decision of my consultant, I arrange the transfer issue.
Yeah, absolutely, you did. What I'm trying to say is that whilst I was saying that most of the people, if you mentioned, then if you missed a couple, then that should not be a problem. But don't miss your consultant. That was what I was saying. I know you discussed with your consultant. I'm trying to point out that who are the main, roles in this communication, who are the most important ones. So sometimes the examiner can be a bit, bit nosy, and they can try to explore what will you do next. What will you do next? So they're trying to see who did you talk before before the next step. Have you missed a step in between? Sometimes they can be, and then they can bring you from a pass to a borderline. Okay. So you said you will talk to, about the court, you said you will talk to the obstetrician of the other hospital. And then you said, as I wrote it down, you said, then the pediatrician will be talking to the pediatrician of the other hospital. Now, what I will say, you will make your side complete first, okay? First of all, you will liaise with your neonatologist, okay? So we prefer to say neonatologist rather than pediatrics, but it's okay to call pediatrics as well, okay? So the neonatologist would be a better term. So you will first of all speak to your consultant. After talking to your consultant, you will speak to the neonatology registrar. Your consultant can speak to the consultant neonatologist, but you don't have to mention that, that's fine. Even you can, if they say that neonatology registrar is not available, say I will talk to the consultant, okay? There's not a problem that you can't talk to the consultant, you can, okay? So you say that if neonatology registrar is not available, I will speak to the consultant neonatologist on call, okay? There's always an on call in that team as well. So afterwards, you will say that I will speak to the labor ward coordinator as well, because, or you can even speak to her before, because the patient is in labor ward, she's contracting. You would have talked to your consultant, he would have agreed with you that, you are right, you're doing it right, that you've given her some tocolytic, or you may be asking him whether I should quickly put her on tocolysis and all that. And you would have given steroids anyway. That's an ST5 level thing that should be done without even any input. That should be fine. Okay. So you would have discussed with the labor ward coordinator at that time. So you can mention, just go natural, and you will mention that I have already involved labor ward coordinator. If you're talking and you later on realize that you didn't mention labor ward coordinator, you can always say that, yes, I wanted to mention that I would have involved labor ward coordinator right in the start, okay? Because she's taking care of the patient. And we would have discussed that she's for the in utero transfer. I will then, my next approach will be trying to make sure that the team is accepting of the patient. So I will talk to the neonatology registrar in the neighboring units. And once he's saying that, yes, we can accept this case, we have a cot as well, then you will let the labor ward coordinator know, and she will talk to the labor ward of that hospital to arrange a bed for the mother as well. Okay.
Yeah.
So I'm talking about the sequence, that if you want to fine tune that this is the natural sequence, okay, then of course, once this is done, then you talk with the not you, the labor ward coordinator speaks to the ambulance staff. Okay. So if they say you can talk as well, there's not a problem, but it's usually they are adept at doing these things and they do it. Okay.
Yeah. So labor ward coordinator who will arrange the ambulance as well as searching for the available cot.
So available cot, you will be searching with your neonatology counterpart. Available cot, neonatology will be talking to the neonatology team. Okay. Or you can be talking to the neonatology team. That's absolutely fine. You are asking your neonatology team first whether they have a cot. Okay. They can say that we don't have, and then you can either, they can liaise with the neonatology in the other unit. That would be preferable because it will be neonatology to neonatology, and you can talk to the obstetrics registrar in the other unit verification.
Yeah.
Okay.
Yeah.
So, and there's not such big issue. You can say that I can talk, if the neonatology registrar is not available to talk to the other unit, I can give these details to the recipient unit. All that they want to know is that who are the people who will be involved. Okay.
Yeah.
So yeah, once you've mentioned all these and discussed about midwife and ambulance and all that, that should be fine.
Okay.
So would you involve the patient and their family as well? So don't forget that it's not only the communication with them. Yeah, you would say that I will take them on board.
And apologize for her because we don't have available code and we obliged to transfer her for another hospital, and we already arranged, and she will have a hard copy for the transfer itself. Yeah. One more question. I always stuck in this point, Sam, really. Because my understanding of how things go there, that when patients come in the emergency and the patient, for example, have either pain and or the patient who get acute retention, and I asked to see her after a while from the obstetrician or the gyna opinion. So I think that this patient come to the emergency and already one of the emergency doctor see the patient, give her painkiller, or the other doctor see her and put a catheter on to relieve the retention. Then I will go for confirmation these things and confirm that she is comfortable to talk. Then we can go for the consultation.
What? Sorry, confirm what?
Confirm that she already comfortable right now and she can talk, and we can go for the consultation. This is I think how things go.
This is how it happens. You are right. When patient comes in emergency, they do bleep you when they find out that this is an obstetrics or gynecology patient. They do bleep you, but they don't stop managing the emergency. Okay, so they will take care of the emergency. They would have, if they think that this is a retention of urine, they would have emptied her bladder. Okay, and they would have done all the baseline tests in the meantime. They would have, if it's a reproductive age patient, they would have done a pregnancy test. Okay, so they would have done the baseline things. Yeah,
because some speak about this patient, for example, who get retention, I will introduce a tube which called the catheter again. So already the patient relieved from this retention issue. The patient will not feel you retention until you come. I think this is my thinking. Some speak about I will speak with the patient.
They will relieve the retention before you come. Okay, if you are receiving a phone call, you will, even if somebody is asking, oh, she has got retention, you can say that Can somebody please, you know, do an in and out or put a catheter in to see, to relieve her retention and to measure the volume, okay?
Yeah. Okay. Because somebody says about this issue, the patient already in retention, you should first introduce catheter by aseptic condition, and the patient then comfortable. I say,
Yeah,
wow,
that
already
you don't
it is
do
done.
enough. It's not you. If they're asking you how will you do that, you say that. But they're not okay. They're not trying to see whether you know how to do catheterization in a
Yeah,
patient. Yeah,
I
they
think
want to
so.
know
Yeah, I think
whether
so.
you can manage or not. And management
Yeah.
is that A&E would have relieved the you know, the retention of this patient. You know, they can't just leave her because the obstetric or gynecology registrar will come and under his auspices things will be done. So no,
Yeah.
you're right, absolutely right. They would have done it. You don't have to describe those things, okay?
Yeah.
Unless the
Because I
examiner
think
asks you, how will you do that? Then that's a separate issue. You say, well, the guy, A&E team would have done it. I wouldn't want them to wait for me. So say
it also have
if they're saying that you are on call in, say, gynecology or obstetrics, say I might have emergencies going on in obstetrics and gynecology, I would not want them to wait. So suppose, for instance, the scenario is that you're receiving a call from A&E. This is the A&E F2 talking from, you know, FY2 talking from A&E, and he's asking that we've got this retention patient. You will not see, okay, I'll come and I'll manage her. You'll say that, okay, I have got, you know, whatever the scenario they've given you. If they said that you have 2 patients in hand who require emergency, you know, management from you, you can say that, yeah, I will tell the FY2 that you know, manage the patient like this, like empty the bladder. If you want some investigations, say, I'll ask them to send to do a dipsticks and then send for an MSU as well, because in retention you always want to rule out whether this is because of some UTI or not. So you will say it over the phone. They will not be waiting for you to come and do it. Then you'll say, as soon as I'm finished with my, you will tell this to FY2 that I've got this you know, emergency bleeding patient going on, and as soon as I manage her, I'll come downstairs and or downstairs or wherever. In my hospital it's downstairs, so it comes to my mind downstairs. So I'll come to anyone. Yeah. Yes.
Okay.
Yeah. Okay.
Sometimes I think also the fault communication is also tricky, as well as the missed communication.
Yes, faulty communication and miscommunication, both should be penalized, isn't it? So I would want you to know that in a station, what else can come in a station which, if you didn't do, can count as a poor communication skills with colleagues. So I want you to brainstorm, think of other things. Other people can think of other things as well. What do you think, if you didn't do, would count as poor communication with colleagues? Anyone? Anyone? Wake up, girls.
Sorry, what was the question?
Come on, girls. Don't make me think that you were not attentive to what we were asking. Come on, that's demotivating. So the question was that what are the other things that you think are included in communication with colleagues? In any station given to you, what would be other things that the examiner is looking at? If you didn't do those, they will be counted as a poor communication with colleagues. Anything?
Yeah, I think regarding communication with colleague, especially in teaching station, because you are dealing with colleague.
Absolutely.
Yeah, and
very good example. Yeah.
That means we should cover what the colleague concern at that time, and inviting question and asking feedback from the ST1 whenever we are arranging some teaching station, and also we ask if everything is okay with him, and in order to exclude bullying or anything that mean the ST1 or the colleague is comfortable in her work. There is no any problem facing, no any problem regarding training, regarding with colleague, that mean communication with colleague. Also,
Yes,
these are
yeah.
important. We should cover it.
Yeah, good. Anybody can add anything to this one? Sunanda Sahana.
Yeah, of course.
Yeah,
One point
Sanat.
regarding the bullying. Yeah, regarding the bullying. Sometimes we only ask how things go with the department. Is that sufficient to exclude or screening for bullying?
I will come to this one. Okay. So is asking enough to? Okay, let's address it right now. So what do you think? What else can we do, Sanat? So suppose, for instance, Sanat, if you asked how is your how's everything, and you're saying that is this enough to exclude bullying? So the junior says, I'm your junior, okay? Ask me, is everything okay? Ask me.
Yeah, for example, can I start? Hello, I am Sanat ST5 and you?
Hi, I'm Sam, I'm ST1.
So Sam, I noticed that you joined our department recently. How are things going in the department with you?
Yeah, everything is okay.
Yeah, okay. So Sam, all of us here as a team always should be supportive to each other. And at any moment of time, you feel that there is something worrying you need more support in, you can contact me personally or anyone, and support will be there. How that sound?
Yeah, okay, okay.
Okay, so what we say here, Sam, will be always here. And of course, sometimes we can go through hard times in our work. If you feel that's the case with you, you can talk with me and we can try to find solution together.
Yeah, thanks. Thank you.
Okay, so would you like to discuss with me anything before going for the discussion our session?
No, it's okay. It's okay. I'm fine.
Okay, so I can't go further.
This is what I mean. This is what I mean.
I see
So
from the body
now try
language
it again. Now try it
again.
again. Try it again. We'll compare the two scenarios, okay?
Okay.
Try it again. Now start again.
Okay. So hello, I am Sanad ST5 and you?
Hi, Sarad. I'm Sam. I'm ST1.
Yeah, I know, Sam, that you recently joined our department. How did you find the
I
department
did,
so far?
yes. Yeah, I did.
Yeah, that's great. Yeah, yeah, it's great to know this. Yeah.
I'm
Okay.
loving
Do you
it
have any
here,
particular? Yeah, that's fine. Great to know this. So before going into our discussion, you would like to have any concern to share with me?
Not at all, no. Sorry, I came up
that's
with this
okay.
question. The only thing is that I'm bothering you with my question. Otherwise, everything is fine.
Yeah, that's great. So we can go for our session, blah, blah, blah. So from the body language, there's no bullying.
Yes, yeah. Now you tell me what's the difference and why were you not able to manage in the first one? I am telling you, you were not able to manage, okay? I am telling you. So what happened there? What happened there?
The body language and the non-verbal communication.
Absolutely, verbal and non-verbal communication both. Like verbal communication, although verbal communication not only includes the words that are being said to you, it includes the tone of the voice as well, isn't it? And it's got so many cues were there for you. You kept saying we are here to help you, we are here to help you, but I kept saying everything is okay. But you know, what was the key sentence that you could have said and I could have opened up? You didn't say that. Anybody can say that?
Confidentiality. Yeah, we should tell her that whatever we discuss will be confidential. Not mean No one will know about that in order to able to explain if there is any bullying or undermining behind this. That's mean low
This is a
tone.
very good point. One thing is missing even before this one. I was thinking, I had in my mind this point, but before this, there's another one, and that's the vital one. That's the groundbreaking one. Yeah. So can somebody else think of that? What happened here?
So we can ask, like, I could see that you are looking a little low down. Can I ask you what is bothering you?
Excellent. Excellent. Yes. Yeah, absolutely. So Sanad, you would have said, oh,
Yeah.
you don't appear to be fine. You don't seem to be fine. Then you could have said, you know, you can share with me, and I assure you that everything will be confidential until you wanted me to share with somebody. So I don't look fine. You could have said, Sam, but you don't look fine. And I could have said, oh, I just want to discuss this patient with you. And she said, that's okay. We'll just, is it an emergency? Okay, I'll hand this over to somebody else to deal with. Just forget about the patient. Come here and tell me. This is how we do in real life in our departments. If somebody is like that, and if somebody is, you know, for instance, somebody is coming from, you know, gynae assessment unit, they have a patient set of notes with them, and they're saying, this is what we need. We'll immediately say, give it to me. And we'll ask one of our colleagues, we'll call them and say, are you able to help me with a kind of a semi-urgent situation? And they'll say, yeah, are you able to see this patient, please? There's something urgent that we need to do here. And then you can, you know, take the person in privacy. You don't do that in exam, of course, but in exam, you say, but you don't look fine. You don't seem fine. There seems to be something bothering you. Please have, you know, confidence in me, and please, you can, we'll keep everything confidential. You can either talk to me, if you're not comfortable talking to me, please talk to, you know, your somebody senior, some educational supervisor, you know, I'm here. And then assure her in various kind of words, okay? You get my point, Sana? You were absolutely lost. You were like a girl is crying. What?
Yeah, absolutely good, really, Sam. Thank you very much. Thank you. I get your point. So I already see that there is something
challenge
wrong.
Them, yeah. Challenge them. Say you don't seem fine. You're saying something else, but something else is happening. You don't seem fine. I'm concerned about you. Right? You can write down these sentences, and you can, you know, use them in the exam. Because in exam we are stressed and we tend to forget. So you can use these sentences. You don't seem fine. Okay. You can trust me. You don't seem fine. Okay.
Yeah, absolutely right. Yeah, thank you very much, Sam. Really, thank you.
Good, very good. So anything else that you think comes in communication with colleagues? This was a typical scenario of teaching where you are excluding bullying and everything. Okay, one question I have. And that's related to the teaching station as well. Okay. Now this is a teaching station, the CTG. I am an FY2, and a midwife called me. She said, this is the CTG of this station, and I want your, you know, views on that. And I'm like, I'm on the FY2. What I'm going to tell you about CTG, and I'm rushing, and I'm coming to, who do I come to? I'll come to Sunanda. So I'm saying, oh, hi, Sunanda, can I please bother you with my question? So what are you going to do, Sunanda? This is a teaching station, but it's in a clinical scenario. What are you going to ask me? Let's start. Either you can start or anyone can volunteer. I don't mind.
So you are FI2 and I am FI2, or you are FI2?
You are ST5.
Okay.
You are ST5. Okay. So I'm coming to you. So hi, Sunanda. You are ST5 on call today, aren't you?
Yes, I am.
Oh, hi, Sunanda. Sorry to bother you. I have this CTG. When I was in the you know, in the labor ward, and the one of the midwives, she just stopped me and she wanted me to comment on the CTG. And honestly, I don't know anything about CTG. So are you able to tell me anything about, can you go through the CTG and tell me, you know, give your opinion about the CTG?
Yes, definitely. Let me look into that. and let me have a look, and then definitely I can teach you what is CTG. Before that, Sam, I would like to know what all information you have regarding CTG, so that it will be helpful for me to discuss and teach you properly.
Oh, I don't know anything about CTG at all.
Okay, fine. So
I only
let
want
me
to know what do you say about this CTG, and what do I tell the midwife?
Okay, fine. So let me have a look what CTG we're having. Before that, I would like to discuss the basic information regarding CTG. CTG as such, Sam, it's a graph where the fetal heart, so many things are there. So let me draw and show you. This is the fetal heart rate, the first one, which runs at the first part, that is 110 to 160, which is normal.
Oh,
And
yes,
then
so this
down,
is normal. Yeah.
yeah, down one, can you see that there is one more graph which is running down?
Yeah,
So
what's that?
yeah, that is uterine contractions, what the patient will be
Oh,
having. Yeah,
okay.
we have two monitors, two parameters to look into. So along with uterine contractions, the fetal heart rate runs. So are you getting me, Sam?
I'll stop you here. You did very well. I'll stop you here because we are
Okay.
only doing the communication part. So I'll stop. I'll relieve you of this burden. Very well done. The thing that I loved is that why you didn't ask about bullying or something. Why you didn't inquire? It was good, but tell me why you didn't inquire about bullying.
Because I thought that this ST1 or FI2 is eager to know the CTG. He's eager to learn the something. So
Okay.
I thought like, okay, I should not.
Did you think this was not the time to ask about bullying, or did you think that you didn't think that bullying was happening in her case?
Because the FI2 came with the CTG graph. So I thought maybe he is eager to know because he wanted to know about the graph.
There was no
Not that.
suspicion of, you didn't get any suspicion of bullying,
Yes.
or you didn't think that this was the time to discuss?
I didn't think that FI2 had some bullying because he was into the system and he was in the labor ward. He wanted to know what is happening. So
Okay.
should we have to ask questions? I don't know.
No. Anybody else, if this was the same thing you would have done, then why would you not ask me about bullying?
Absolutely,
from-
bullying is
sorry.
there.
I have one
Sorry?
question, Sam. Yes, Sam, I can interrupt you here. So
Yeah, sure,
if
Tamina, go on.
if FY1 come to me to know the CTG, first of all, she told that she want to tell about this CTG to the nurse, but I have to assure her that, oh, okay, FY1 you, so it is not your that you have to tell the nurse that CTG, because this is not her. This time she don't know anything about CTG, so this is not her duty.
You can assure her, absolutely. You can assure that yeah, it's a bit complex thing for your level, but I'm happy to teach you if you want to learn about that as well. Okay.
Okay.
That
The
is
tone
one
of the
thing, and
voice.
also his tone of the voice is not like this. She is upset or anything, low mood. So
that was the answer I was looking for. Excellent, Tamina. Excellent. So I think Sunanda knew in her mind, in her subconscious, but she was not able to speak it out, that she is not able to pronounce it out, that she didn't bloody look being bullied. Okay. So why would I ask her about bullying? She's so happy. She's like, she's talking like almost singing. So why will I ask her about bullying? And that's natural. You should all know that if the person is so, laughing, smiling and all that, and socially she's absolutely kind of talking to you in a vibrant tone, then you don't worry about bullying. You can't start asking about bullying in that station. They'll think that you are stuck with your agenda here. Okay, do you get this point?
Yeah, that's a great. But I have query regarding the bullying from the junior, not from senior. Sometimes the bullying or undermining may be from the junior to you, for example, from the nurses to the doctor.
Absolutely, it can happen.
FY. Yeah.
Absolutely.
So for this case, that the midwife who is working, for example, for the unit for the last 5 years, and this FY2 who are not obliged to even comment on the CTG. So I have a query regarding the bullying from this midwife who is expert and have plenty of experience in this department, and this FY2 who come only for months, maybe 2 to 3 months, and she bullied him regarding things what he don't know, and
So
of course
I
he
would,
will not allow it to comment on it. So if I see from his gesture when he go to me that he is little bit ashamed about the deficient knowledge, so I will put him confidence. For example, ask her to search for ST to comment on this CTG. And if you have interest to know more about CTG, I will tell you everything. You are not allowed to comment on it. Like that.
yeah, you are, yeah, allowed is a bit strong word, but yeah, you are not, we don't expect you to, be able to comment on
Expect,
CTG. Yes, yeah. You know, you keep these in mind. These words, some words are a bit strong and some words are a bit more suitable. But yeah, what you are saying is, even if this was the case, even if there was element of bullying from the midwife, the doctor would not be that happy. Okay,
Yeah,
so
of course.
they would look worried. They would look that they are worried that, you know, I would come like this, you know, can you help me, because I couldn't explain this to the midwife, you know. Yeah, I'm so sorry. It's so embarrassing that I don't know about CTG. I would talk like that. So if I haven't talked to you like that, that only means that maybe I was in that room for, say, some cannulation, okay? And the midwife thought that she would want to know from the registrar, and sometimes they don't know whether the person in front of them is FY2 or ST2. Okay, sometimes they just don't, maybe they are new, we don't know. You're saying that she's there for years, but maybe has joined also, she's a new joinee in the department, so she's not aware that, you know, and she just missed it that this person is FY2. She thought she's on call team, you know, like ST2 maybe. So that's okay. If the person came to you in stress, then that would be less. You ask, okay? Give me a second. Give me a Nazim. Sorry, guys, for the interruption. So, yeah, so you get my point that if that was the case, you will always follow the body language of the person who's coming to you, okay? And the tone of their voice. Yes.
Sam, I just wanted to know, it has come like in a hurry, who wants to learn, like as you given the scenario. In that situation, should I tell that agenda, like, no, today I will discuss normal CTG, then I'll discuss about your CTG, what you are bringing.
So here I was going to point out one of your mistake, okay?
Yeah.
How you proceeded, because you have in your mind that this is a teaching station, okay? So you did, first thing you did good, you didn't ask about bullying for your own reasons, and that was good. You did good, that's what counts, that you didn't ask about bullying because I was happy, chirping and all that. But what you did next was you started, you placed yourself in the teaching template, okay? Yeah. You fixed an agenda in your mind. Why you didn't ask who is the patient? What happened? Who is this patient? What you started on? You know, talking about. Let me tell you about CTG 160 to 110. You know, 110 to 160 is normal. But first thing that you will ask, okay, tell me about the patient. What happened? So, what's the patient? Is she? You know, and then they will tell you. Then you'll ask whether consultant-led care or midwifery-led care. If she was midwifery-led care, why is she having a CTG? So I tell you the example. They could say, we don't know why. So you will ask about the risk factors then. That if they didn't mention to you risk factors, you will start probing. Is she, you know, having high blood pressure? Does she have this? Does she have this? Okay. So
Hey, doctor, we can use Dr. C. Bravado, Minomoric.
Absolutely. And Dr. C. Bravado, you don't have to first say about Dr. C. Bravado, because that again puts you in the template of teaching that kind of gives you an impression. We don't do that naturally in our clinical life, that the person is coming and we start saying like that. So we first ask who is the patient, and then later on when this, when we start commenting on CTG, we say that as we just determine the risk of Dr. C. Bravado, are you aware of Dr. C. Bravado? And then you can start talking about that. Okay, so it's okay even if you said it before, that would be fine. But I want you to play really natural there, so that it looks like that the person has come to you for a patient, okay, to discuss the CTG. You don't just go with the agenda of teaching station there, okay? Go natural.
Yeah, got it. Yeah, I was assuming that I had to teach like as you said, like a template. So I didn't use.
Please forget about templates. Templates are there for you to practice, but they are not there for you to make them, like a Bible that you only have to be fixed on that track. You have to absorb them so natural that they become natural. You don't want them to be highlights and underlines that in bold text. Now step 1, step 2, step 3, step 4, make it flow naturally. That would be fine for a template. Okay.
Sam,
you won't in a natural clinical scenario, won't you ask about the patient first? Yeah.
Sam, this is Shamim. How are you, Sam?
I'm good. How are you?
Yeah, fine, thank you. Sam, I have one question. Like, as you said that we don't need to ask for, bullying and everything, as the the student was very happy and this thing.
Just say, is everything okay with you?
Yes.
You can cover it with this one. Just say, how are you doing? How are you doing? Everything okay with you? That's it. This is what I did in my station. Hey, how are you doing?
As all the mentors, they always say that this is one point. If we don't just rule out the bullying and undermining, so we will miss one point on one tick in the checklist. Then so.
No, if a patient, you have to see the body language of the person. If they are happy, you just ask, in a light tone, how is everything? Are you enjoying in the department? Good. And you smile as well and you say, good, very good. And you've ruled out already. You don't say, oh, everything will be confidential, and they will be saying that, are you a psycho? I'm laughing.
No, that thing I won't say. Yeah, that thing I won't say. Just one line where everything is good.
Just one line, one line. You say, is everything? How are you doing? No more than that. You say, hello, how are you doing? Yeah, everything okay? Okay, good. So what do you have for me? So they'll say, okay, I was in taking bloods of a patient and the midwife wanted me to comment on the CTG. So, and you say, oh, sure, let's see it together. So then you will start asking about you. So what happened with the patient? What's the patient? You know anything about the patient? So,
Okay, thank you.
Like okay. Yeah. Anything else for now? Okay, now please come on, guys. I'm still on the first question that I asked when I began. What are the other things that you think will be counted as communication with the colleagues? And nobody has still mentioned. Okay,
about doctor referring for MDT also is necessary. That means how we refer the patient for MDT and we explain for them, because MDT also is. Yes, it's one that
MDT referrals are a communication. Okay, MDT referrals are a communication with colleague. What else before that? Even before that, and that's a good thing that you remembered, Neman. I'm so pleased because nobody was talking about written communication. Communication with colleagues is not only verbal; it's written. It's verbal, it's written, and then it's in the body language as well. Okay, it's in your tone as well, just like if you are smiling to your colleague. Okay, so what else? GP letters. Okay,
yes, GP letter,
GP
referral letter,
communication with colleague. Okay,
referral letter,
GP specialist if it is required.
All, absolutely, all the referrals to specialists. Your letter to the midwives, okay, they're all communication with colleagues. Okay, the what else? Your mental health referrals, yeah, urogynecology referrals, all that. How about if you put incomplete information in the referral pro forma, like you're sending it to fertility clinic or urogynecology or something, and or on oncology, and you didn't fill in adequate information, that is poor communication with colleagues as well. Please remember, okay? That is poor communication. You did not give them enough information and you started expecting their help, okay? Do you get that? Anything else? So you guys can switch on your mics and say, okay, rather than typing in there. I'm not very good in reading the chat.
Okay.
Yeah, so, hello, Sam.
Yeah.
Yeah. One more question, Sam, if you don't mind, also regarding the communication.
You know, I don't mind it.
Yeah, that's great.
That's a good communication, though, that you are asking, you know, politely. That's a very good communication. Go on.
Thank you. Thank you. We already learned from you, Sam. Really, thank you very much.
You are good in communication with colleagues. See.
Thank you. So
I don't know if you understand. I don't know if you, because few of the words of Urdu and Arabic are alike. In Urdu, we say Ustad Kamil. So, you know, and then what do we say? Shagird Kamil as well. So means that if the teacher is, you know, good, then the students are good as well. So
yeah,
I'm taking the credit.
Thank you very much.
Now you are already good. I was just joking. You are already good.
Really, it's very enthusiastic session. Really, thank you.
You're very welcome.
Yeah, sometimes I see some colleagues who do practice, and I see them speak in detail about, for example, I will ask the midwife to put cannula, and I will ask the nurse to put the leads, and I will ask my anesthetic doctor to confirm that everything is okay on the monitor. Then I will examine you in the presence of a chaperone. So too much detail. Sometimes I am afraid I may lose some detail or just mention.
It depends what situation are you talking about, okay? So if this was a collapse patient and this was a structured discussion and you were telling to your examiner, what will you do? Then you first of all make your point to discuss the major things that will be happening. They really know that the midwife will be, if you can say it in not half a minute is too long actually. If you can say it in 10 seconds that, you know, midwives can help us scribing and the anesthetic colleagues and the nurses and all those people can help us, you know, cannulating the patient and all that. You could say it in a minimum kind of sentence. That's fine. Examination with chaperone, are you talking about a SPT? Or are you talking about the collapse patient? Because don't say that, because all of them there are
different. Yeah, too much difference. Yeah, of course. Yeah.
No. Yes. Don't say chaperone and examination there, please. In the collapse patient, they're all there, so there's no chaperone.
Yeah, all there.
Yeah, absolutely. And you know the main focus in collapse station, what is the main focus? And I think if you just cover those with a little bit of fillers here and there, you will secure a pass in there. The main thing would be that first of all, you called for help. You made sure that your consultant is informed and called on the floor, okay? Okay.
Yep.
You made sure that anesthetists and whoever relevant, you have named them. Okay. If you name few of them and you miss few of them, that would be fine. But you name few. Okay. So anesthetic registrar, I'll make sure that my consultant is informed to attend the scene, and I'll make sure that all the on-call team, including the anesthetic registrar, attends the this emergency. Okay, with the press the buzzer, you've made sure of these things. Then what else is very, very important in this, that you, after the initial measures, that they want to know whether you did the breathing or the chest compressions first, only that one. And maybe somebody will like to know the ratio of the compression to breathing. If you could make a paragraph and rote learn that paragraph, but then say it naturally there. Okay. And then what they want to know is after 4 minutes, what you are going to do. 4-minute bang. They want to know without prompting, 4-minute bang, what you are going to do.
Yes.
Okay.
Yeah, very important.
And what you are going to do.
Very important.
Everyone knows.
Yes. Very important. Yes, Cesarean section.
Very modern section. This is what they want to. This is what to. Decision at 4 minutes, delivery by 5 minutes. Okay.
Yes.
Are you trying to save the baby? You must say that this is to save the life of the
It's
mother.
a resuscitation. It helps in resuscitation of the woman.
Absolutely. Say it in one sentence. At 4 minutes, I will decide. They don't want to hear rest of the nitty-gritty stuff. If they know that you've covered these 3 or 4 major things, and you definitely want to say, I will do it right on the spot. My emergency trolley will have a knife there and a clamp. So I will do it right on the spot, not moving to the, so you have, if you say this without prompting that, if you forgot to say that I will not move the patient to the theater, and they prompted you, and then you said, they will probably still give you, some mark there, but they will want to hear it from you. But you are saying that I will do a perimortem section, decision at 4 minutes, done by 5 minutes, right at the spot. No worry about the bleeding or the pain at that point, because this is a collapse patient. We can take care of these things once she's resuscitated and this her circulation is established. This is what they're wanting to hear, these few points, and they know that you know what you're doing. Okay.
Yeah.
So I agree with you that nitty-gritty, you go into that nitty-gritty, you'll do this, and what happens is that the time is over. You had to say 5 important things. You know what I do? I say the 5 most important things before anything else. I know I can go into the nitty-gritty of FFP and everything later on, but I first want to tell them this thing, that I know this. Please don't dare marking me less on that.
That's a great video. You make the exam easy, Sam.
Sorry.
You make the exam easy than our expectation.
Yeah, please. You know what? Honestly, I realized after my exam that this exam is actually being made difficult by various, I don't want to say the word, but by various people who are guiding that, you should do this, you should do this, you should do this. Actually, it's much more simpler. It's much more simpler than it's being made to look like. And people are failing, not because it's a difficult exam, because they keep their attention towards all those points, that I have a list of, I made an Excel file to see what were the feedbacks given to and it just is a joke. I was just laughing that why are they focusing on these tiny little things? So you get distracted to very little things. You don't feel, your focus goes on to minor things and you lose the forest for the trees. What do I mean when I say you lose the forest for the trees? Anyone knows?
Sorry again, Sam, please. Sorry again.
So if I say you lose the view of the forest for the trees, what do I mean? So I mean, you imagine a forest, yeah? Imagine a forest, okay? So are you guys still with me, yeah? So imagine a forest, you have to go back, you have to step back a little bit and view at the examination and the station as a whole, okay? Rather than going too close to the tree, like to minor things in a station. When you focus too much on the minor things on the station, you lose the view of the whole forest, okay? Is anyone with me on this?
Yes, of course.
Yeah, you see what I'm saying? So if you are into the nitty-gritty, very tiny details, then you actually lose the holistic view of the station that you have, but you're not able to say because you are stuck with that one tree, okay?
Yes.
Or few trees, okay? So step back, tell the examiner you know the whole forest, okay? Then if they say that, okay, focus on this tree now, then focus on that tree, okay?
So the holistic approach from our obstetric and gynae approach. Yeah.
Absolutely. They want to know that you know the big fat things, okay? If they wanted to
Yes.
probe you about the small things, they will ask. If there was something that was big fat in their eyes, but it's not really, you didn't think it was big fat, then there is a little risk that you will score a borderline rather than a pass, because if you did it too many times. But not for one or two mistakes, really, okay? So mostly you will, what I will do, I will go with the big things, forest, okay? This is there, this is there, this is there. And then if I feel that there is something that this examiner might be considering, you know, equally important, then I will focus on that. Or if I thought that this was, if I have time in hand, I will then start, you know, coming to the trees. This is what I will do, okay? So first of all, give all the bigger things, then you come to that, to the minor details. Okay, so have we covered most of the points that could be considered as communication with the colleague? Let me see if I have. In the meantime, you guys can think if there was anything you wanted to. So what do we have here? Yeah, I was so surprised why can people fail this one. Okay, so do keep coming up with your questions. Okay, so we said this was what I was, we already said talking to colleagues in clinical areas or phones. Yeah, I didn't say that, yeah? So nobody came up with this one, that when you are in the clinic or in the you know, or you receive a phone call, wouldn't that be communication with the colleagues? Like people are working around you, that all is communication, talking to the colleagues, communication with the colleagues, okay? Letters, referral letters, discharge letters. You are giving incomplete information on the discharge letter, you're writing abbreviations, that will all be a poor communication with the colleagues, okay? And oh yes, nobody talked about this one. Do you see which one? Listening to? Can somebody read this and tell me why nobody's talked about this one? Open up your mics, whoever wants to say, yeah?
We cannot see the slides.
I have shared the slide. Why are you
Slide is not changing.
No, not changing. Yeah.
Is there a slide in front of you?
Yeah, there is, but it is only the
But does
first
it-
slide.
Is it really only the first slide?
Yes, it is first slide on the screen. Hi, Sam.
Oh, okay. So why is it? I have changed the slide here, so let me. It's not good. So
Now it has changed.
Oh,
yeah, now it has changed. But if I make it big, can you still see?
yes, we can see.
All right. Okay. So now we said underneath the discharge letters and MDT performers, there's a point that I've written. You're listening to a patient. They come up with a complaint. Okay. What's your poor communication here? What can be potentially your poor communication? See? Can you read this? So you have to listen to the complaint without accusing, blaming, or undermining your colleague. Okay.
Okay.
Yes.
You don't say, oh yeah, he always does this. Okay. She's saying that, oh, he examined me, you know, like very, I felt so much pain and all that. Oh God, I'm so fed up. He always does this. So don't talk like that. Okay. You know, or don't say, oh, okay, yeah, I understand. Yeah, there are other people who are complaining the same. So don't say things like that, okay? Don't try to win the favors or win the heart of the patient by accusing your colleague, okay? That's not empathetic approach. Empathetic approach is only be empathetic with the patient, but don't accept the responsibility lies with your colleague because you don't know. So say, oh, I'm sorry this happened. We can always, you know, if if you felt that way, would you want this thing to be, severe enough to be, do you want this to, if she keeps on complaining only, then, yeah, if she says just one, you just say, I'm sorry you felt that way. I even say that, oh, he's a good colleague. So I'm surprised that it happened like that, but I'm sorry if you felt that way. That's not putting the blame on your colleague. I'm sorry you felt that way. And she insists that, no, I'm very upset about it. I think something. So then you say that, oh, I'm sorry it was that bad. Yes, we do have a system, where you can complain through PALs and all that. Not everything goes into incident reporting, remember? Okay, so your colleague has examined, this does not, incident reporting has certain criterion. So this doesn't normally come under incident reporting that she's saying. So say PALs leaflet and all that. Okay, so that will be, basically, we're not talking about how to handle patient complaints here. We're talking about what can be considered as a poor communication with colleagues, like your behavior towards colleague is undermining. You are quickly accepting that, yeah, they could be wrong. Yeah. So that would be a poor communication with colleague as well, indirectly. Okay. So, yeah, patient says this one in blue. Someone wants to talk about this one? Yeah.
Yeah, this below sentence, Dr. Sam.
Yeah.
This below sentence, yeah. The patient
Yeah, what would
who
you say? Patient underwent laparoscopic selping or oophorectomy because she came in emergency in pain. Okay. You went to talk to her and she says, I don't understand why that you never did my scan. What would you say?
Yeah, I can see that you are upset, and can I know why?
So she wants to know from you why.
Yeah, so I can, of course, communicate with my colleague to see why it is late for you. And sorry for that.
If you are saying this, is there anything before this that you could say to calm her worries down?
Yeah, I'm sorry. I'm sorry that's happened for you, and I will search and ask, discuss with my colleague why does it happen for you.
But maybe you don't even have to be sorry, Sanat. This is my point. I'm trying to come to another point. Maybe the situation is that you don't even have to apologize.
Can I try, Sam?
Yeah, Rhoda, please.
Can we tell to the person, for every condition, some list of required investigations. Maybe in your case, it was not required by the rules.
And why? Yes, it's a possible answer. And why would you say that it probably was not required? She came with a left-sided pelvic pain, severe enough. She was taken to theater. So why would you say it was not required? You are right, but what do you think is the explanation?
Can we tell that I will go through your notes and I will see how urgent was your situation and what was the best actions to be done by our staff?
Absolutely. Here lies the best clue, okay? Because she's saying that, and this should be your response. You're saying, okay, so you didn't have a scan. So Jane, I want to tell you that please don't worry about that. I will look into this. It could be that you came in such a severe pain and maybe the clinical findings were strong enough to indicate that you really needed an urgent surgery in theater. I will definitely look into your notes. I can assure you, if this was something that could have been done and that was missed, then we will definitely look into this. Okay, I could do an incident report on that if it was that. But most likely scenario I can explain to you, Jane, is that you might have come in such an emergency that any delay to wait for a scan would have delayed your surgery and made the situation even worse for you. So I think normally in such circumstances, your safety is so much important that they would have not done it. But I will have a look at your notes, and if there is anything, I will share with you. Okay.
Thank you.
Make
Sam,
sense?
is it incidence report? Is this something we should mention and discuss with the patient? So is it something I should tell to the patient? The sentence incidence report. I was thinking it is just for the doctors and some the medical relevant stuff.
We can use the word that we have a system to log in any happenings, any happenings of omissions. That is for our learning and investigation, internal learning and investigation. Okay, we can say that I can do an incident reporting, by which I mean that we have a system to log in such omissions if they are found to be omissions. We have a system to log in those things. But I'm quite, I will be able to comment after I see your notes. I have this impression that this was done because you came in such an emergency and it was necessary for your safety. Okay, so if you have, in one sentence, once you jot this down on a piece of paper, you can make like 1-2 sentences out of this, and you can say this to the patient. So her worry is over. She knows now 2 things. She knows that I don't need to worry unnecessarily, because this can be just natural for my own safety. It was nothing of an omission. But at the same time, she believes now that you have said that if there was an omission, then you will find that out and you will not let it go uninvestigated. Okay.
Okay.
You have answered her both the concerns. Okay.
Okay. Sam, can I ask?
Yeah, sure.
I have no impression that any station we say I will involve my consultant, it will be right way. Is it really true and right understanding? Should we always tell that I will involve my consultant or I will inform the consultant like this?
Not in all the cases, no. You will not, in normal, just a normal kind of usual scenario, you will say this wherever you think the situation is complex enough. But you have to think of criteria in your mind. Are these decisions usually made by a junior person, or you are ST5, so you are at kind of a middle level, or these are done by a consultant? Sometimes, for instance, if I see a patient, I say that I'll get my consultant's input as well in your care. For instance, if this was, what example can I give? If she was a diabetic patient who I was going to book for induction of labor because she was a macrosomia, I can decide that on my own. I'll inform my consultant just to, because consultants are aware of all such cases, but I will not get input for care. I will not say I will get their input for your care, because I'm trained that much to be able to decide about induction of labor in such a patient, but yeah, we'll inform. So you have to balance where there are complex cases, then you say that I'll get input from them in your management, okay, if there are complex cases. If that's a simple epilepsy coming in and wanting to have, just a preconception counseling, then you will say that we will, a multidisciplinary team.
Aya, sibiha. Sibaya Aya. Sibiha, oh, ini sibiha. Hala ya akhi.
So okay, sorry for the distraction. Okay, so what I'm saying is that you just see that wherever you think are a bit complex, cases, you will say, I will get input, and where there is not complex, you can manage by saying either inform, or like in epilepsy, I was giving you example that you will just say that, in your preconception period as well as in your pregnancy, a multidisciplinary team will be taking care of you, involving our consultant obstetrician. So you have involved the consultant without saying that I will not ask input, because it's only epilepsy, and you will involve in that kind of way that there will be a team of, of obstetricians and neurologists and GP and all that looking after the patient. Okay.
Thank you. But it will not be considered as a mistake if we will just mention. But we will inform our consultant. It will not be considered as a mistake, right?
If you are saying, if you are using the name of the consultant as informed, that was not a mistake at all. But if there was a breach delivery, ST5s usually wouldn't have done breach deliveries. We don't do a lot of breach deliveries. So you will not just say, you know, just you want to make sure that the consultant is a part of the decision making. So you will, in that one, you will escalate it to the consultant. I will talk to my consultant and involve him in the decision making. That is for that one. Okay. So, but in normal other cases, you can say that I'll inform the consultant. Once you have said inform for normal, all these kind of medium type of situations, that should be good enough to score. But if you are saying that there is a patient who's going to need a cesarean hysterectomy and you're saying inform the consultant, that would be gross, mistake. And because you need a consultant there. And then if similarly, if there's a placenta accreta going for a section and you're saying, we'll inform the consultant and say, okay, go home. Okay. Because that will be such a big blunder to say just inform, because the consultant should be doing the section in a placenta accreta. Okay. Even if you are thinking in your heart that I am an ST5, I can do accreta, I've done 4. So, but for examiner ST5s, they are not all the ST5s will be signed off for placenta accreta. Okay, so you will need to distinguish between what are the things that ST5 cannot. Don't think I can do or I can't do, because some of you may be consultants in your hometowns, so you don't think what I can do, think what an ST5 can do. Okay, and then say that I'll
Thank you.
involve my consultant. Okay, yeah,
yes, clear. Thank you.
Very welcome. Also, please remember that use the word, I think one of you was it Nemat or somebody was mentioning the word, or Tehmina was mentioning the word nurse for the nurse gave this CTG to FY2, and this is bullying or something like that. But it's not nurses, it's midwives. Okay, so it will be nicer to say midwives when it's midwives. Okay. Nurses will be where there is a maternal medical condition and the nurses are involved. Okay. So what else? So let's quickly go to sum up the points that we think that could score us, could save our souls, I should say. I was going to use the wrong word. So in the exam and communication with colleagues, what are the points that can save our souls? Okay, so let's, I don't know whether it's going to change the slide, so I'll go back and I will, come on, what's happening?
Sam, can you make it a slideshow?
Yeah, it doesn't go there. I try to, it doesn't go there. Okay, so also, I would want to highlight that you have to be, when you're correcting mistakes of people in teaching station, please don't shy away from telling that this is a mistake. Okay, you don't have to always say that would it be better this way or would it be better this way. Okay.
কত বছর মিরিতে যাওয়া হয় না এরকম জায়গায়।
Okay, so yes, please. So if we are talking in a teaching station, would you if you were to see abbreviations written on a discharge letter, on a consent form, abbreviations, what are you going to do? Even in the discharge letter, especially the consent form, how will you tell the junior about them?
We will just inform that in the polite way. We will say, because patients usually they don't understand the medical terminology. We have to.
They are hurting, Miss Urine, hurting a lot, and now they are around. These also I notice around
what a pipe also.
What's happening here? Okay. Sorry, Rhoda. I don't know what was the distraction. Can you go on what you were saying?
We just will tell to the junior that because this is Latin, we are writing to the patient who is not relevant to the medical field. We have to mention every condition and procedure by simple words without using terminology. Can you please
Yeah.
can you please try now to say this by the simple words? Is it fine to say like this?
Okay, this is one good point. Anyone else? They have written LSCS for lower segment cesarean section. What would you say to the colleague? How would you correct them?
Hello, Sam. Vishnu Priya here.
Hi, Vishnu. How are you?
I'm fine, dear. Yeah. This is regarding LSCS abbreviation. I would tell my colleague or my junior, whoever it is, tell him that according to GMC, for patient safety, we need to put it in a full form, not the abbreviation form.
Yeah, good. Very good. Very good. And anybody else wants to add to this one? This is the most important point. Anyone wants to add? Anyone wants to add why LSCS, the person has written LSCS, and you are trying to tell them why they should not be doing that? And how would you tell them?
According to GMC, we have a set of rules and how we go about. We should not write in this. We should not say we should not write. It's better to write in the full form than the abbreviation form.
So you were going absolutely in the right direction and then you just turned back. No, this second version is not correct. Okay. Because the second version, you're saying that it's better. It's not like it's better or not, because it's wrong or right. Okay. So you can't be that polite, because if you are polite, they will not learn, they will not know that it's not, it should not be done. They would just think, okay, doctor is too much perfectionist and write it the same way. That's fine. She's saying it's better. I don't have time to do better things. I have time just to finish my job here. Okay, so it's not only better. The correct thing was what you said before. Okay, that this is GMC guidance, and it's our legal consent form is a legal document. And you cannot use abbreviations in the legal document. This is not lawful. Okay, so you have to write the full name of the procedure. Okay, don't shy, don't beat about the bush. Don't say, would it be better that way?
Okay. So we can also say, Sam, we can also say like, because it's patient has to understand. So it should be in the simple form.
Patient has to understand, should be in the simple form, that's fine. But you have to for them to understand that how bad it is, how bad, how important it is. You have to use some harsh words which are the truth. Otherwise they could, next time they ended up still writing LSCS, patient went for, procedure. They later on sued you. They said LSCS, we thought it was like, something else. They could construct anything out of it. And then your consultant calls this, the junior and says, did you write this? And they say, oh, I was only told that it's better to do it that way. But I talked to the patient, she understood it was this. So when as far as she understood, I didn't mind writing, because when I was talking to her, she said, I know what's LSCS. So you have not explained that this is a legal document. It doesn't matter, you don't have a recording of your conversation with the patient. You have to explain. That is another aspect that the patient should understand. That's very important. But equally and even more important is the legal aspect. Okay.
Yes.
Yeah. So you have to clarify. You don't beat about the bush. You don't appease. In medicine, they want to see how good leadership qualities you have. There is there is a role of politeness, but equally important is the role of assertion. Be assertive when you have to tell the correct things. Be assertive. You don't have to beat about the bush. Is it okay? Would you prefer it that way? Do you not think it should happen this way? That's not the correct way. Whoever is saying that this is how you should teach, is that it doesn't apply to abbreviations. It doesn't apply to writing drugs without their dosages. It doesn't apply to writing wrong dosages of the drugs. Okay. Yeah. So for these things, you have to be a bit assertive. Okay.
Yes.
Otherwise, this is a missed teaching opportunity, missed learning opportunity. Okay. You just wasted your time and the other person's time. It was a fruitless exercise if you're not able to convey what actually was it that you are expecting of them. Okay. So that is communication skill as well, being assertive when it's required. Okay. So if you did this thing in the teaching station that you are asking, would you think it's better this way? Then they will think that you are not conveying the message. Okay. Your communication is lacking the assertiveness where it's required. Okay.
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 So that's it really. Just the tips. Be yourself, relax that you are in the clinic, and just like you would be in your clinic, and where we go from there. So does it become big now? Let me know if you are able to see it now. Are you able to see?
Yeah, we can see it, but we need to zoom it.
No, I have made it, like on the.
Sam, we can read it. No problem. It's fine. Even
No.
without zooming also, we can read it. I think you made it, you enlarged it. It's fine. It's good actually.
Wait. All I want is that you are able to see. So is there a number 1 in front of you on the slide?
Yes.
Okay. So
Yes.
this is what I was trying to focus. So for people who have got a problem with English, I'm afraid they need more time to sort that out. There's no shortcut to not knowing English. We are lucky people, most of us, that we got our basic education in English, so should be fine. You remember that accent is not a problem. You don't get any negative marking for your accent. Okay. It's only the problem is when you cannot explain to the patient or you don't understand what the patient has said. Okay. Yeah.
Okay.
In the RCOG course, I saw somebody from some part of the world. That was, it was terrifying how much, they knew so much. This was a girl who knew so much. I could tell from how she was coming up with various, theory. Okay. But the problem was that when communicating with the patient, she was not able to explain anything. And she was not, when the patient was saying something, she was not getting what she was saying because she was not used to talking to patients. Okay. So if that's the problem, that can take time, that can take long time. 2 months is not enough for that kind of thing. Okay. If somebody has got more time, then I say watch English dramas. But otherwise, if you only have a problem with accent, that should not be a problem. You're not penalized for that. Okay. What have I written with NHS and British culture? Now when you're preparing for the exam, that some things that you hear that this is not how you should talk to the patient. You find it strange, isn't it? Why can I not tell the patient I am the doctor? Is that a feeling you guys had? I had it when I came to UK. I was laughing that I am the doctor. It should be me telling the patient, this is suitable treatment for you. This is suitable treatment for you. Do you guys feel the same way? In our cultures, patients, if we said to the patient that you choose, they will come back to us and they say, doctor, we came to you. Please, you choose. You tell us what's best. How do I know what's best? So in UK, there are few patients who told me this thing that we would want you to choose. How would we know what to choose? But most of the patients here would want their, choice, freedom to choose. Okay. So here, if you try to dictate to the patient, you are too paternalistic or you are imposing on the patient. You will not do that in the exam. Okay. Any comments on this? You try to impose your choice in this without saying that, these are the options and we'll respect your choice. You don't always have to say, you have to behave. You don't always worry about, I have to say these words, I'll respect your choice. No, you don't always have to. You just explain to the patient things and you say that this is something that seems to be safer for you. And you are waiting for her to respond. You are giving her a choice. It's all about body language and all that. Sometimes you can say it out loud. If you haven't said it, but you did not impose on her, that is equally giving, equally fine. It's equal to giving choice. Okay. Does it make sense? Any questions?
Yes. No, it's clear.
Good. Okay. So yeah. Are you able to see slide number 2? Is a slide with a number 2 on that?
Not yet.
Not it. It is still 1.
It's still 1. That's Zoom is a bit incompetent.
Yeah.
Now it is 2. Yeah.
Now you can see 2?
Yes.
Yes.
Okay.
Yes.
So these are your scoring points. Please, if I am summing up these scoring points for you, if anyone fails this domain, I'll jump out of that window. Okay. I'll make sure there's something underneath you so I can follow you. Okay, but I'm sharing you, summing up the points for you. Note these down. Okay, this is my teaching material, so just note this down in your head or on your paper, that if you don't miss these points, you will not fail this station. Okay, I can guarantee, if you stick to all these points, you will not fail this domain. Okay. First thing I said was, don't impose, respect British culture. Okay, don't impose, don't be paternalistic. Forget that you are back home where the patient says, you are my Bob, you decide. Okay, here it's like, we decide, patients decide together with the doctor. Okay, so that one, and then I will write to your GP. Don't leave it to the end. All the tick boxes, get them ticked in the start of the station. Okay, right? And we already discussed how to do that. Okay.
Yes.
And I'll move to the next, but I'll have to go back for that again. So, okay. Yeah, you get this point? For all the medium ones, you say, I'll inform my consultant. For all because you get the consultant box ticked. Okay. Say, I'll inform, and if they're complex, say, I'll get input from my consultant. Okay. Yeah.
Okay.
Now tell me one thing. If the negotiation fails, you're talking to the patient. Now this is even extreme. I'm ahead of this one. The negotiation fails. What's your sentence there?
I will arrange another appointment with my consultant.
Well done. Yes. Yeah. Okay. So that is one step ahead. I will arrange you an appointment with my consultant. Please don't say this sentence to all the cases who come to your clinic. I have seen that everyone keeps saying, I'll arrange an appointment with my consultant. Your consultant will fire you. Okay. Don't say for every case, I'll arrange you an appointment with my consultant, because you are doing your consultant's clinic there. Okay. So he'll fire you. He'll say, you saw the patient. If she has to come back to me, then why on earth are you sitting there? Okay. So I've seen that people add at the end of every station, I'll book you an appointment with my consultant. So no, sorry, you will only receive your discharge letter from the hospital, your goodbye letter, your firing from the hospital. Okay. So don't say that. Your consultant will be fed up. So I'm joking about that, but yeah, okay, don't say that for everything. But when the negotiation fails, or when the case is too complex, you can say, and also, the transgender cases, we don't treat them. Okay, it's like they come to us and we refer them. We treat them if they are like the things that are within our, capacity, like easy ones. vaginal discharge and all that. But if there is anything that is specific to their situation, then we say that we'll book you, we'll refer you to the appropriate clinic. Okay. So that is okay to have an appointment there. But other than that, don't do appointments for everyone. Okay. How do you score? This is your next point. We all know, always say consultant-led care, always use the word MDT. Even if you don't have time to describe MDT, just say MDT involving various specialists, okay? Relevant to your condition. And always say joint clinics, okay?
Sam, this appointment for the consultant will be like on the same day or some other day?
Some other day. Some other day, okay? Not on the same day. Never on the same day, okay? Yeah? So you get this point, this everyone knows. You're scoring here, you don't forget. How do you not forget about this point? Why do people still fail if they know this point, if everyone knows this point? Because as soon as you start talking about the management, this is the first thing you should say. Don't leave it to the end. The Marfan's recording that I uploaded, I said it in the end. But that was when I had just started my preparation. So I've forgiven myself for that, okay? But don't say this in the end, yeah? I'm saying don't say this in the end means that, you don't leave it to that you forget, because the time could be over and it could be on the tip of your tongue and the time was over. So deal with it as soon as possible. This is what I'm saying, okay? Has the slide changed to 5 or not?
No, it's on the 4.
I don't like this. So
yeah, it's changed. It's 5.
Yeah. So what's the next scoring point for? I will liaise with the consultant under care of you, under care of whom you are, okay? Neurologist, cardiologist, whatever. You're scoring here for the communication with colleagues. Sanat, you think these points, if you are saying all these points, still there would be room for you to fail communication with colleagues?
Really, I don't think so, but we should remember.
Yeah, you practice, So you practice.
Yeah.
Absolutely. You make it your job to practice like this, okay? Whenever you're talking, you just think, because you still have few weeks to prepare, okay? If you prepare everything, don't focus on the nitty-gritty of things, okay? Don't focus on that. Listen to your station when you recorded it and listen to whether you addressed these issues or you didn't, okay? If you didn't, then you don't really need other people's feedback. You just need to do it again, okay? Yeah?
Sam, can I ask when we should say about specialist nurses? If it is something related to the maternal medicine, then only specialist nurse?
Yeah, only that. Only in those cases, okay? Only in the maternal medical conditions. And similarly, if there is any, fetal medical condition, when ultrasound will be required, then sonographers, okay?
Okay, thank you.
And the fetal medical doctors in most of the conditions that will come to us, they will need 1 or 2 of these, okay? But what I'm saying is, if you mention these, you're scoring marks on communication with colleagues, okay?
Okay.
Okay.
Sam, in oncology.
Before I forget, should we write back for the midwife as well as the GB for the maternity cases?
Why? This question has been asked so many times. What's with this question? Yes, indeed, whoever refers you. I'm sorry I laughed, Sanad. I don't mean to.
No problem at all. We just to learn, of course, because I even hear and I surprised why I write for the midwife, already midwife in contact and the GB there. We write only for GB who have the record of everything for the patient.
Yes, whoever has referred, you respond to them. And why I laugh was because day before yesterday's, or I think yesterday, Sunanda asked this in our other group. We have a small group of friends for some long time. So she asked me there, I replied, and she didn't read my reply. And then when we started this session today, she asked me the first thing, about the same. And I said, I replied and you didn't read it. Now you are asking.
Yeah,
Yes,
sorry.
No, I'm just laughing. I enjoyed it, actually. I enjoyed
No
it.
problem.
I don't mind any question, but I like to laugh when I can. Okay, so
Yeah,
I
that's
do
great.
apologize. That's not to belittle anybody or anybody's question. I just want to be, to enjoy the session wholeheartedly. Okay, if that is
Yeah,
if that feels like that I'm doing something wrong, you can quietly send me a direct message saying that that don't do that, and I'll stop being.
absolutely not. Absolutely not,
Okay.
Sam. It's really make it light.
I know I can be a bit naughty, but that's with all respect for all of you. Okay.
Yeah, of course. Yeah.
Okay, great. So yeah, don't forget about mental health. What I say is that mental health, to most of the complicated cases, even when that's not a part of the recall station that you have read, it could be because they didn't think that way. Mental health offer mental health support to all the cases where you think that this could be some stressful pregnancy. Okay, pregnant and non-pregnant as well, all the urogynecology, all the chronic conditions where you think that they will not be able to, that this is stressful for them. You can, have you been feeling, so they say, I'm so fed up of this. As soon as if the patient hasn't said, then still, if serious condition or prolonged condition, you can offer support. And if she has said that I'm so fed up with this now, then as soon as she says that word, you should think of mental health support. Okay, do apologize, say, I'm sorry, I'm really sorry for this. I know it's easier said than done. I'm happy to support you. We have very good mental health teams. Do you want me to refer you to them? And she will say thank you and yes and all that. Okay, so remember, this is a good communication point. This is a very good communication point. It should score you very well. Okay,
Sam, should we tell mental health services or counselor, Sam? How is it? What do you say?
you can use any words, but they don't mind. Mental health is not a stigma here. You can use,
that's what.
we can, yeah, it's not a stigma here. It's it may be stigma in other parts of the world. So here you can say that we have counseling support available. So yeah, counseling support, yeah, it's a polite and nice word. Okay. Okay. Then what other scores are sitting there for you? It doesn't go on that view. Okay, so all these, you are all aware of this, but in the station, don't forget, as Sanad pointed out, we all know, but we forget. Okay, so remember, you don't forget. I'll try to tell you how I did that. I kind of made boxes in my mind, box 1, box 2, box 3, box 4. Not only in my mind, I drew them on a paper. Okay, so first box was introduction, agenda, then history of present illness, then so sorting out those histories like that. One box for past, like medical history, surgical history, allergies and all that. Then in the end, when there was this plan of management, I got used to talking about all these referrals right at the start of that. Okay, so if you are, and after the plan of management box, if it's a pregnant lady or preconception, or also postnatal part as well, where we talk about postnatal stuff. So if you make my boxes in your mind, you will. And I actually colored my book. I'm very much color oriented. You might be able to see from the slides as well. I love colors. So I put the colors on my boxes. So I can't forget if they are in colors. Okay. So you would have your own ways. You can do your own way. Okay. But try to put, try to categorize things and try to remember in your head a flow. Where are you going? Okay. Yeah, so we all know gynae-oncology, MDT, Macmillan talk about them, urogynecologists, physiotherapists, stress and if you mentioned them to the patients, that is a good part in the communication. This is the most important one. No one of you does this. Why? Can you see? Okay, you're not able to see. Yes. Why don't you do this? How many people do this? Do you smile? Yeah?
No.
All of you are very, very miser in smiling.
Maybe
Why?
in the beginning only.
Huh?
Maybe in starting the station only. After that, mask face.
After that, you are back in the reality and you are like, you know what? Keep smiling all the times. That's your savior. Okay, just your smile should not be like there is a terrible patient thing happening to the patient and you're like this. Don't do that. That would fail you. But yeah, most of the other stations you should you should keep your smile, especially with the colleagues. Okay. You've done patient stations with the, all that, whatever body language we've just talked about. But I'm talking about communication with colleagues. You have to smile. I was laughing in my exam. I told my colleagues I was laughing in my exam. I laughed in more than one stations. Okay. And that's your communication. You should feel light about communicating with colleagues. Okay. They're not horrifying people sitting there. They want to see whether, I don't tell you to laugh there. Okay. I laughed. That's one thing. I don't know whether I scored less for laughing, but I just can't control when I have to laugh. I have to laugh. Okay. But smile is good. Okay. Smile and a lively tone. That's good. Okay.
Yeah.
Now tell me how many people would want to remember that they have to smile to the colleagues. How would you enter a labor ward station? Who is sitting in the labor ward station? Who is taking that? Who is that? A consultant? Anybody knows who is in the labor ward station?
Is it examiner?
It is examiner. In real life, that is a consultant. But in the exam, what are they pretending to be? In the exam, labor ward consultant, examiner, examining you there. What are they pretending? What are they saying? Who are you with at that time? Because most of the times they say that your consultant is half an hour away or in a meeting. Yeah. So they're not your consultant. Otherwise, why would they ask you about the decisions? So who is it? Who are they?
Hand over to the colleague.
Coordinate, labor ward coordinator.
Labor ward coordinator. Even if it was a consultant, I still talk to them in the same way. But, we still laugh with the consultant as well. But it's a labor ward coordinator. Won't you go in and smile and say, hey, how are you doing? Would you? Hello, hi, how are you doing? And she will say, yes, good. How are you? I'll say, good. I'm good. So how's the labor ward board? Oh my God, ouch. So I'm not saying you all do that. I did that because this is what we do normally here. But I'm saying just take it light, okay? It's the labor ward and she's your coordinator. Go in, ask her, how are you? There's no harm in asking her. Some people keep fussing about, you should not say hi because that's not formal. You should say hello. Come on, come out of this, please. Everything is fine. I don't say hello, I say hi. And the labor ward coordinator said, hi there. So she was even more informal than me. So please don't fuss your mind with all these minor nitty-gritty fusses that saying this will mean this and saying this will mean this. It's just the same like a difference between operation and surgery. There's no difference, okay? Yeah, agree?
Sam, in all structured discussions, I was addressing them as sir.
Don't say sir. Don't say sir.
Okay, fine, right?
But I did some like it's. I didn't realize that.
They will not negatively mark you. They will think that you are from abroad. They will not negatively mark you. But it would be better if you said, you know, hi, Mr. Thomas. Hi, I'm Sam. You know, their surname. Use their surname. Okay.
But how we get to know their name? Get to know their name.
There is no name, so say hi, doctor.
Okay, doctor. Okay.
Say
Got
hi,
it.
doctor. So, or just say hi. Hi, yes, I'm
Hi.
hi, I'm justified with you today. So, you know, and they will start.
Because when I looked back, I realized that in all structured discussion, I was addressing them as sir. So because that context has come, I thought I'll better verify.
No. We don't call sir here. Okay. No sir, no madam here, please.
Yes. Okay.
So there was somebody coming from India. One of our friends, she came from India to UK, and she kept on talking about sir in India. And even in India, I was saying to her, please, for God's sake, don't say sir. So when she was here, I said, just stop it now. We don't say sir here. They'll think you're coming from, you know, I said, you sound like a Pendu. And she goes like, what's Pendu? And I said, Pendu is like a villager, you know, who doesn't know anything. So we just laughed about it. It was just, my purpose was to explain that no, we don't say madam or sir here. Okay, no ma'am and no sir. We don't use these things here. Okay.
Yeah, got it.
Okay, so
Thank you so much.
Just say hi and just smile. We use the first name for them. Okay, we even use the first name for them. Hi, Sarah. Hi, Lee. How are you doing? So it's not like back home where you have to do salutes all the time to your consultants. It's like it's much more equality here. Okay.
Got it. Thank you.
So if you are very, very much, you know, if you're given a name, Thomas Morgan, yeah. And you want to say, you know, with respect, you will say, hi, Mr. Morgan, how are you doing? You will not say then, hi, Mr. Thomas, if Thomas is not their surname, okay? You will say, hi, Mr. Morgan. Or if you want to call by first name without using the titles, then you will not say, hi, Morgan, how are you doing? Because Morgan is their surname. Surnames always come with the titles, okay? So surname will mean Mr. Morgan. But if you have to use without Mr., then say Thomas. Hi, Thomas, how are you? Okay? So this is the distinction, but for your convenience, they don't give you full names anyway. So you don't have to rote learn that thing, okay? You just say, hi, I'm, okay?
Yeah, okay.
Yes? Yeah. Okay, good. So let's move on to the next one. Yeah. And this one, the labor ward coordinator, don't call her a doctor, okay? So she's a senior midwife, okay? Yeah.
Okay.
So these points should be enough to pass anyone in communication with colleagues. I don't think you guys have an excuse of failing communication with colleagues. Now, what do you say? What do you say, Sanad? It was your main issue. Yeah? So, all of you? Okay. So Jeet has been very quiet today. I see Divya as well. I didn't hear from Divya as well. Okay.
Hi,
So,
Sam. Actually, I'm on duty, so I'm just hearing you and think it's like, you know.
Yeah.
Really
I just noticed you now actually because I was scrolling and I didn't see your name.
No, but I'm really enjoying, and you know, from last 2-3 days, I'm a bit relaxed. Otherwise, my nerves were, you know, getting hit by, you know, because so many confusions were happening, you know, when you are hearing to a lot of people. But now a bit relaxed I am. Okay, so will you recording, Sam?
I will definitely try to, you know what, because it's a lot of, it consumes time when I'm doing the work and all that. And actually, Jeet, to give you good news, I might be able to extract some snippets from the previous recording, which I thought I'd lost. But what happened was that actually Zoom sent it to me quite late. So I thought that there was no recording. So that was my experience.
Yeah, yeah. But that day I attended your session. Yeah, that was luckily I attended. But this time I'm not able to hear it. Like I missed that
No, it's okay.
whole
It's
point.
okay. I should upload this. Yeah.
Okay, thank you so much. Yeah, it's a lovely session anyhow.
You're very welcome. You're very welcome. How are
Thank
you
you.
doing, Divya? And Divya, how are you? Divya? Hello, Divya.
Yeah, Sam, I'm fine. Thank
Hi.
you. How are you?
How are you?
Good, good, good. Going on.
Come on, you're soldiering on, okay?
Yes, yes.
You have to soldier on. You are our champ. You are the champ in our team, okay? We all are champs.
Your words keep me motivating, Sam. I really don't know where do I stand.
No, it's okay. Why do you say that?
Thank you. Thank you so much.
Why do you say that? You're very good. You are brilliant, and I don't have much concerns. You were guiding us, okay? If you had been in that exam, you would have passed. I'm pretty sure, inshallah, that you would have passed if you were appearing with us as well, okay?
Thank you for your
You
kind
didn't get
words, Sam.
opportunity. You didn't get opportunity. Look, there are weaknesses in all of us. There are few, and we can point it to each other. That should take us to our, the point that we want to reach, okay? To the goal. Is there somebody else trying to say something?
Sam, it's me, Samina. I just reached home. Assalamu alaikum, first of all.
Walaikum assalam. Walaikum assalam.
Samina, I'm so sorry. I'm fine. But I'm so sorry I missed it. But definitely I listened to the recording. It must be.
Inshallah. Well, if you miss it, you just don't have the chance to ask your questions. We can't, of course, do anything about that. But of course, whatever anybody else had asked, you would be able to hear that, okay?
If अगर मुझे कोई क्वेश्चन मेरे जहन में आया ना तो मैं आपकी जान खा लूंगी, आप फिक्र ना करें.
You're welcome. You are welcome. I know that. I've never doubted that. Okay. Okay. So you're not preparing. Jeet is preparing, and inshallah, Jeet and Divya, you're preparing. Sunanda and Vishnu and Samina, you're not at this one. Sanad is preparing. Temina is preparing. Sadia is preparing. Kanmani and Sahana and Aya, are you able to tell me, are you guys appearing in February?
Hi, Sam. This is Kanmani.
Hi, Kanmani. How are you?
Yeah, I'm good, Sam. Thank you. It was an excellent session, Sam. Yeah, as somebody else pointed out, I was so much confused with so many nitty-gritty things, and you solved that problem for me. Thank you so much.
That's great.
I'm
great.
appearing in February, Sam. And
you are? Okay.
Yeah.
That's great. Just make sure that, whatever feedbacks you guys are getting from various people, I've been going through the feedbacks in various groups, and I can tell you that half of those feedbacks are really, kind of making you worried for no reason. Okay, just make sure that you don't get trapped into those worries, because that means that your focus is lost. Because as I said the day when I was doing my session, I said that, if you hear a station from someone, and if I feel that this person has a problem with XYZ, but they are told that their problem is ABC, so your focus goes to ABC, why it should go to XYZ. Okay, so your preparation suffers in that way. So you only need to make sure that whatever your focus is not being distracted. Okay. So most of if these problems are solved, you all have got lots of knowledge. Okay.
Thank you so much.
Very good luck for February. Very good luck. Okay. And what about Sahana? You?
Yeah, I'm here, Sam. And sorry because for emergency call interrupted me. Sorry.
No worries, no worries. So
Yeah.
I knew you were around. Okay, that's fine. You haven't got any question left yet. We covered all the things that you should be able to say, and to save your again, I'll go with the soul for now, to save yourself from failing this
Yes,
domain.
really, yeah, really fantastic. Really, thank you very much, Sam. Really, really, thank you too much.
Very good. No, it's my pleasure. So how about Sahana? Sahana, you are for February exam? Sahana.
Hello. Sam Sunanda here.
Sunanda here, yeah.
I just wanted to know, like, can you do one class on Eurogyne? Because it's quite a big module.
I can always try, definitely. It would not be very soon, because of course I'm trying to find these slots out of my work. So it kind of goes like in another 10 days, 12 days kind of thing. I will definitely try, okay?
Okay, thank you.
And you can always send me a reminder in the group, in the bigger group, I mean, where I would, kind of try to pin those requests, so I have that in my mind. When you say Eurogyne, you're wanting to talk about all the Eurogyne, or some particular aspect?
No, the stations, like common stations, or overactive bladder station, SUI, which repeatedly comes. Those two.
I could try. I didn't try that one because I wanted to focus on generic skills, because the thing is, it's just my work and life balance. I don't want my family life to suffer. So what I do is I go for generic ones first, so that you can pass the domains, because I know the material for the other, kind of specialties and topics is available everywhere. But I feel that the generic guidance is lacking, and there's lots of misguidance about that. That's why I didn't touch any kind of that kind of topic. I thought, and I thought that there was a lot of mess about labor ward. That's why I focus on labor ward as well. But I keep your this point on board, and if inshallah, whenever I find that kind of time,
because one Eurogyne station is comes in that 14th station. So
yeah.
And one more thing I just wanted to know, they say that this starting opening questions, no, can I know your name and age, please? They don't like it, right? Is it like that? Can I know your name and age, please? It's like everybody uses it. I heard that you should not use it for all stations.
No, so what is it that you should use for all stations?
You can ask, like, after our introduction, you can ask Mrs. Thomas, Mrs. Smith. Can I confirm? Is it like that, or we can use?
You will give her name, and then you will say, "Can I confirm your name?"
No, not like that. Then? First, we will introduce ourselves. Then we will tell about, is it Mrs. Smith?
Then no, you will never say her name. You will never say her name. You will never say her name. That can create. You will hear the name from the patient. There can be. The other day I was in a hospital when a wrong person was given chemotherapy. Okay, for the other person. You will always let the patient can hear something wrong. They can have lack of attention. You say, "Are you Mrs. Smith?" They may say yes. Later on, you find out, no, it wasn't Mrs. Smith. You will always ask them, "What's your name?" Okay. May I have your name and age, please? You will always ask them.
And if the patient is already in the hospital and you are in the ward rounds, in that situation, what is
always no, just stick with this one, okay? There can still be a confusion. You will so for instance, you go to bed, you say in the ward round, yes, the patient on the bed 4, she is for nephrectomy, left nephrectomy. She was there for appendicectomy. They took the left bed 4 for nephrectomy while they had swapped the beds. Now it's an appendicectomy patient. So you are going there, you're thinking, oh shit, this is the hospital, it's bed number 4, patient is admitted, bed number 4 was Mrs. Smith. Are you Mrs. Smith? And she is hard of hearing. She says, yeah. So you won't take that chances, okay? Please remember, whether it's admitted patient or whether it's in the clinic, you will say, may I take your name and your age, please? I don't understand, where do these things come? There's a factory of manufacturing these kind of confusions. I mean, what's happening here? You ask everyone, and saying that, oh, because you can't say this in all the stations. Yeah, in all the stations, examiners are different, role players are different. It's not like you are displaying the same design to everyone or something like that.
No, the thing is that if the
Don't
patient
worry
is
about
already in the ward and you know the patient, you are going for a ward round, and they
No.
say that no need to
Answer is
confirm
no.
with-
Answer is no.
Okay,
Okay,
thank you.
there can be bed swaps, there can be so many things. They can be they suddenly move the patient to HDU and now there is another patient. Have you never seen patients changing beds, nurses changing beds of patients or wards of patients? What are you talking about? So whoever is inventing these things, they should actually look at themselves that they are confusing people. Okay,
Yeah.
so
Thank
these are factories of confusion building. Please don't follow these kind of things. Okay, I don't know who wastes that kind of time for all the exam students. Okay.
Yeah, thank you.
I feel I feel nauseous about these kind of people making up these kind of things. Okay, so please don't worry about that. Ask every patient, admitted patient, you don't have any logic to say she's admitted and no, just say, what's your name and your age, please. Okay, because the patient might have swapped their beds, wards, or anything. Okay. Yeah. Anything else that's coming to your mind?
Thank you.
Now, Sananda, you pointed out such a brilliant, like this is something very brilliant that you highlighted. I'm pleased that you said it because this is extreme if somebody was doing this mistake. And if you don't highlight it, others may be getting misguided by this. Okay. So I'm very pleased that
one of the station like in the crash course or something, circuit course, my friend said, I don't know, that the mentor said that you are already know the patient, you are in the ward, and why you are asking the patient name? You must be knowing because you are a part of that. So I was just wondering what happens exactly.
No. I don't know whether you've noticed or not that when you are in the when you see the patient in the clinic and when you see them in the gown in the wards, they look different. So you can't really trust that I have seen this patient in that. And post-operatively, under the effect of all that, they're kind of sometimes look so different, look so sometimes, under effect of all that morphine and their facial, their smiles are different now and all that. It's not easy to recognize, and don't depend on that. It's a medical legal thing that if you are talking about somebody else, but to somebody else, that's a medical legal issue. You always confirm their identity. Don't assume it was you taking care of the patient. Don't, and even if you were, you will confirm their name and age. Okay. Most of the scenarios anyway say that your colleague did or your consultant did surgery. They don't say that you saw this patient before and this is what's happening there. None of the RCOG station is usually like this. Okay.
Yeah. Okay.
Yeah.
Thank
So
you.
always confirm, please. Okay. So anything else? We are 2.5 hours into our session. Wow. Okay. Anything else, girls?
Yeah, thank you very much, Sam. Really amazing, amazing. Really. Thank you very much. Yeah, makes things clear and easy.
You're very welcome. Okay, all of you guys. So I'll say bye here, unless you've got a burning question, anyone. Otherwise, let's call the day. Okay. Good luck and
Thank
bye.
you, Sam.
Okay. You're very welcome. Bye-bye. Bye all.
Bye. Bye. Bye.
Bye. Bye.
Bye. Thank you.
Bye.